And get started. We're beginning the last quarter of the task force work, and unless there's some extension at some other point. So obviously what we're working towards is the final report that will be issued by the task force in December. That'll be compiled with both the help of our consultants and BLR, and you'll begin to see drafts of that in October and November, so that we can all be comfortable with the report that we issue at the end of this year, in preparation for the General Assembly to convene in January and take whatever legislative action gets enough support to pass based on the report and the information that we're able to provide them. So we're going to keep working towards that goal, and we will have meetings each month until we get there. We have a couple items that aren't on the agenda, so we may ask for the task force flexibility to suspend the rules and amend the agenda just a little bit to accommodate some schedules, and I'll go over that in just a minute. Mr. Co-Chair, you got anything to add? Okay, first item is item C, to adopt the minutes from the July 11th meeting. They're in your packet, Exhibit C. Do I have a motion to adopt the minutes? Motion by Senator Raper, second. All in favor say aye. Aye. Minutes are adopted. Okay, before the Stephen Group comes forth and issue, they've got a lot of information in the report that you all should have already received, but it's also, you've got the hard copy there. One of the things that was asked at the last task force meeting, there were a couple cleanup items that one of them made the agenda and one of them didn't. One of them was the status of the DD wait list, which we are going to have as an agenda item later today. But the other is we had some questions about uncompensated care and the impacts on hospitals and UAMS and the state as far as uncompensated care goes. So there were some questions that came up based on some of the information in the reports at the last meeting, and many of the folks were out of town and they hadn't had an opportunity to look at it. So I've asked the Hospital Association, Jody Ann, to come and comment to that, and then also Dr. Ron from UAMS. So if it's okay with the members, can we amend the agenda and put this item forward? Without objection, we'll go ahead. So Ms. Tritt, if you'd come forward. And in general, I think the question that was asked was there's still some uncompensated care costs. And I think somewhere in the idea that uncompensated care would go away. And I think what we need a little clarification on is what has truly happened with uncompensated care in hospitals in Arkansas because of Medicaid expansion, and what you project would have happened without it.
Okay, sure. I am Jody Ann Tritt. I'm the Vice President at the Arkansas Hospital Association, and I certainly understand your long agenda, so I promise to be brief. I will say that uncompensated care has definitely been reduced since the private option was implemented. Last year, I think you all will recall, the Health Financial Managers Association worked with BKD, which is a consulting group that does a lot of work with our hospital financial folks, to try to do an analysis on what uncompensated care would have looked like without the private option and what it in fact did look like based on a survey that was sent to our members. With that, the survey showed that $149 million of what would have been uncompensated care was actually paid for through folks utilizing the Arkansas private option and having an insurance payer source. That was for 2014. We do not have numbers for 2015, but keep in mind we were anticipating between $350 and $385 million in uncompensated care when the reduction of $149 million had occurred. Hospitals still do see a lot of uncompensated care. Folks have a hard time understanding kind of what it is. The quick and dirty response, and if any of you want a whole lot more detail behind the numbers, we can talk about it, but the quick and dirty is bad debt and charity care together. One of the things that folks sometimes assume is in the compensated care number is what we call underpayments, and those are not included. So if an insurance company pays us less than actual cost, or if Medicaid pays less than actual cost, or Medicare, those numbers when we asked the questions were not included in the $149 million or the estimated $350 million we expected to see. That's a completely different number, which means cost of care and how you're actually paid would be substantially greater, if you will, if you figured those numbers in also. I know you wanted me to be brief, so I will answer any questions that you might have.
So you said in 2014 you were expecting 350 to 385, and that was reduced by about 149, so about 50% reduction is what you would say?
Yes.
And I guess, would you just explain, if we've got 0 to 17% on Medicaid and 17 to 100% and 100, and then you got the exchange, why are people still showing up without a payer source?
That's a very good question. Some folks don't understand that they have the ability to sign up for insurance. Some people choose to not have insurance. We have a subset of folks who come into the hospital who choose not to have insurance and pay their own way without any sort of other supplemental payment. That number is dramatically low, but we do have folks who come in and make individual contracts with hospitals for care. The other thing to consider, the health department has lots of information in its databases, in a hospital discharge database. And in 2013, I believe, you might want to check my year, I'd hate to tell you something that's not accurate, but I believe in 2013, the health department started collecting information on emergency department use as well. So you can kind of see who's coming into the emergency department and who's coming into hospitals and their payer mix source. The other huge source of information for you about folks who are between that 19 to 64-year-old, 138% of the federal poverty level and below, is the insurance companies themselves who have products on the marketplace who can give you information about what those folks look like and who are new users versus who signed up in the previous year.
Okay.
But to answer your specific question about why are there still folks who aren't paying, that's all over the board about who can have access to insurance, who knows they have access, et cetera, and so forth.
Okay. Representative Ferrari, you're recognized.
Thank you, Mr. Chair. So let me clarify. So the numbers that you're giving us now are just numbers that are people that actually come to the hospital, and the hospital spent money treating these patients. Now, you're figuring your money off of cost, off your cost report?
Cost.
Off cost report, not what you would have got reimbursed.
That's correct.
So it's a little different.
Well, not the charge master. There's a huge difference in what we say we would charge versus what the actual costs are. And I can get you my exact formula if you want it, because we do have,
I
you've been
understand.
a hospital
Yeah, I
CEO,
understand.
you definitely know how complicated
Right,
those
and
things get.
So I guess for the task force, we're never going to get to zero uncompensated care,
Correct,
because that's just the way it's figured. I mean, if everybody had insurance, we still would have zero.
correct.
Right, okay, thank you.
Okay, that's all we have right now for you. There may be some more. Dr. Ron, would you like to comment on, from UAMS's perspective?
Well, thank you. Thank you very much. I'm Dan Ron, Chancellor at UAMS. And as you know, I was asked about 10 minutes ago if I would comment on this, so I don't have prepared remarks.
So you don't have a PowerPoint
I
presentation?
don't have PowerPoint, not yet, but I can have one in an hour. Let me just begin by kind of going off topic. I want to thank Governor Hutchinson. I want to thank General Assembly for the $4.5 million that's been provided to UAMS and rainy day funds for fiscal year 17 to support our educational mission. I want to say that's very much appreciated. Our experience, we're an integrated entity. We cross-subsidize from patient care to support education and research. I've got figures that are configured a little bit differently. If I look at our self-pay category, that was 15% at UAMS in the month in December of, what would that be, 14? And is now, for the fiscal year we just completed, is around 3%. So there's been a dramatic reduction in individuals in that self-pay category. For the first time in a long time, we participate as through intergovernmental transfers. We have disproportionate share payments. This past year, we did not utilize all available disproportionate share funds available to us for the first time, and that's because we had fewer entirely uninsured individuals. So it's had a dramatic effect for us. We must generate an operating margin on our patient care enterprise in order to cross-subsidize and cover the shortfalls for our educational expenses. We've got 73 different programs, 3,000 students and 1,000 graduates last year across all colleges. We are able to maintain a tuition differential between our tuition, say, for medical school and what is charged by the private institutions because of our ability to cross-subsidize from the clinical enterprise and also because of the assistance we get with state support. Our state appropriation is less than it was in 2010. So when you compound that along with its purchasing power, our dependency on patient care revenue to support the educational enterprise is greater than ever before. So UAMS's ability to accomplish its mission is really linked to this. To get to Representative Farrar's question in one regard, I listened to a report yesterday on the way to the airport to pick up my wife, coming back from visiting one of our kids, about the Young Invincibles. You know, there is a group of individuals who are eligible for insurance on the exchange who simply believe that they're invincible and they choose to not purchase insurance. This has an effect on the actuarial analyses, it has effects on rates, it has effects on a lot of different things. But part of this group who come in uninsured are individuals who have an illness or an accident who have believed they simply didn't need insurance. So there will always be this group, this reservoir of individuals who are uninsured, but it has been reduced dramatically.
You talked about a reduction from 15 to 3%. What does that translate to in dollars of uncompensated care roughly?
Last year, we cross-subsidized our educational enterprise from our patient care enterprise to the tune of $70 million. And we would not have been able to do that. We had estimated previously about $65 million swing. I haven't asked that that be trued up, but it's in that range at UAMS, the positive impact of the newly insured.
I'm sorry, you said 65 million?
We had previously told this committee that that was our estimate of what the impact would be were it to go away. I have not asked that that be trued up to actual dollars, but I can get that number for you. But it's in the range of $65 to $75 million positive impact since passage of Arkansas Works.
Yeah, and I guess, and for you also, Jody, when can we expect some 2015 data and information that can now match up our predictions versus our actual experience?
Am I on? We can certainly ask the Health Financial Managers Association to do another survey using the exact same questions that we asked for the 2014 data. We like to do that after October because of the way the systems all work within each individual hospital. If you need it before then, we'd happily ask them to.
If you do it in October, when would you have, are you going to have it prior to the end of the year?
We can certainly strive for that.
Could I make a suggestion, Senator? One of the things we had the Stephen Group do so that every year we wouldn't need to start from scratch deciding what are the relevant cost factors, what is the relevant scope for the cost factors, what were our assumptions, and what were the actuals, rather than having to recreate that every year at every hearing. We had the Stevens Group create a grid, and the grid has actuals, and it has our estimates, and it covers all of these things. Projected, uncompensated care with the private option, without the private option, and all of the other metrics we're talking about. And the opportunity to update not just your one particular number, but the entire spreadsheet. So we can go from the projections for 15 and 16 and update with actuals is something, John, if you guys could do that, and then coordinate those in there, and then we can see the whole grid. That's where I got my $300 million that we talked about ad nauseum during the special session, and we can see whether it was 310 million or 290 or some other number. Does that sound like one way to get it all in one place versus ad hoc, or is there something that doesn't achieve with regard to this particular question?
I think in order for him to do that, if you need the actual numbers from the hospital, we can collect that and get it to him through the survey mechanism. I still think it would be first of the year, end of December, first of the year next year. I would love to tell you that everyone responds to surveys really quickly, but it doesn't turn out to be the case all the time. So there's quite a bit of calling and following up that you have to do periodically.
Dr. Onsame, is it realistic to have some 2015 data by the end of this year?
Yes, we're in the middle of, we have an external audit every year. Our auditors are in right now. That audit will be done by October. We'll have that information by then.
And Charlie's right. We just need to coordinate with the Stevens Group and let them,
Sure.
Compare that with the data they've got and try to have something. Because obviously, I think that'd be important to be a part of our final report is, no kidding, what happened the first couple years
Right.
of this. Senator Ervin, you're recognized.
Thank you. Hi. Sorry, you may have asked this question. I was outside. But I'm concerned with, I have phone calls and constituents who are working, who are on the exchange, who have purchased their insurance through the exchange, but their deductible is like $6,500, $7,000, $10,000 is their deductible, plus, you know, their monthly premium. They're not able to afford some preventive care measures like mammograms. And so where, my concern is like a new shift in uncompensated care of self-pay. And I'm concerned that these individuals who are working, who are, have purchased their insurance but cannot afford, you know, a $500 hit for a mammogram or an MRI or CT scan, things that, particularly and breast care is not able to cover them anymore. So, you know, are you seeing a new kind of shift and dynamic in uncompensated care of people that just aren't able to pay their bill at the hospital? I mean, we're seeing it in clinics, but I'm also seeing the fact that they're just doing without mammograms and things like that, that their insurance isn't covering, and that they're not able to really just afford.
So what we're noticing is not marketplace plans. So it's not the 138% of the federal poverty level and below folks who are having those issues, nor is it the folks who have subsidized plans from 138 to 400% of the federal poverty level. It's the other insurance plans where folks have really high insurance deductibles and they're having a difficult time paying their copays, deductibles, and payments. The nice thing about the plans on the marketplace, specifically for mammograms, is that they are already covered as part of the preventive care plan without copays and deductibles being applied. So I will be happy if you've got specific constituents that you're having trouble with. I might not be able to help so much on the clinical side. You might need the medical society and other folks for that. But if they're having trouble in the hospital side of things, I'll be happy to help figure out kind of where the problem is and the divergence in the plans.
Okay, yeah, I mean, I think that would be good. And I know specifically some folks that do have the marketplace plans that really are not able to get some things that they've normally been able to get, so.
But mammography in particular should be available as indicated by guidelines without a deductible on the marketplace.
Okay. Well, I'll follow up with you on that, and thank you.
That's all we have. I appreciate you guys, short notice. You have something else you'd like to add, Dr. Ryan?
I do. I wanted to, Senator Desmangas come in. He wasn't here when I made my comment before. I just wanted to I thanked everybody, and I want to thank you for your leadership for the funds, out of rainy day funds for UAMS. Thank you.
Well, he was opposed to it, but not really. Okay, members, we're going to get back on track with the agenda. So, John, if you'd bring your group down. We've got the Stephen Group update. You, again, have got that in your package, and he's going to track us through these different items and tell us what they've learned the last 30 days. So again, just state your name for the record, and you all are recognized.
John Stephen from the Stephen Group, managing partner.
Stephen Palmer with Stephen Group, senior consultant.
Sheila Cooper with Stephen Group, senior consultant.
Richard Kellogg, senior consultant with the Stephen Group.
Thank you, Mr. Chairman. We're going to try to go as quickly as possible here, knowing that there's a lot to cover. So I want to go through this agenda. If we could take the first slide. So there's been an awful lot of work on the behavioral health and development disability savings initiatives over the past month. And we're working with the department closely and collaboratively in trying to monitor and help to make sure we get you all the best information possible. And this relates back to the savings matrix that we're going to be working on for the final report for you all to consider. So these are really important issues in your high-cost population. We're not working on the long-term care side right now. You're going to hear more today from the department. They'll continue to work with the folks and the stakeholders, and that's something we'll review at the next month. The independent assessment instruments you're going to hear about. The independent assessment issue is so critical to achieving a number of program savings. And I also want to make sure I say this at the beginning. This is not all about savings, and Director Gillespie has been pretty clear on this. There are going to be areas where they have to also add to costs. And she wants to make it clear that, we'll talk about savings, which I think are really important for you all, because that's something that you benchmark, you can hold them accountable to. But in order to achieve these savings, you have some downstream costs and some other areas that absolutely need some additional funding. So it's all going to be a balance. It's not all about savings. The patient-centered medical home savings update we're going to have today, briefly, and I've asked my team to go through these slides as quickly as possible. We'll answer any questions, but there's plenty of information here, and we can always be available to any task force member. We're going to give you an update on the medically frail question. Senator Dismain at the last meeting really created
John, can I just interrupt real quick, again, for the slow learner group? With the long-term care folks, we've got a memorandum of understanding
Correct.
that details cost savings that are going to be tracked over a period of years.
Correct.
With the healthy group, I'm just going to call it, we have a PCMH approach that we're implementing and expanding that we understand, but we're making it more rigorous.
Correct.
With behavioral health and DD, what is where are we in terms of conceptually, what's the tool or the approach we're using to focus on savings in that group?
We're going to go through that in detail today. That's one of the reasons.
Is there an overarching, like memorandum of understanding, industry agreement,
No.
PCMH model? So
No, it's just a number of initiatives that the department is moving forward on, which come out of our recommendations to you, which you've adopted in the preliminary report in December. So they are absolutely adhering to this task force's recommendations.
do we
We'll
have
talk
a
about that.
dollar target then that the initiatives add up to, or, I'm too
Yes.
stupid to do
Yes.
things as one-offs. I have to have some total that I'm arguing against, otherwise I never know whether I'm on track or going in circles.
Yes, they are uncomfortable at this time giving you an estimate of a number of savings, the actual numbers. I don't disagree with that. We are going down to the code level with them, looking at claims to identify what potential impacts could be. This is a very exhaustive exercise. You will get that in the September meeting. That's
Last
something-
question on this. So when you say they are uncomfortable giving a number, can you tell me who they is?
That's the department's leadership, because
I understand. Thank you very
and
much.
to their credit, and this is what we've been working on, which you'll hear for the past month and a half, taking our estimates, if you remember, our estimates in the beginning came from a few state experiences out there. Louisiana, we looked at Texas, we looked at other states, and we're not adopting managed care, but really you're adopting.
John, here's what I know. Washington DC has decided we are going to exorbitantly expand spending on health care. That's what Washington DC has pushed out
Yes.
to all 50 states. It is going up, it's going up dramatically, and it's not going to stop. The only opportunity we have to have any control at all are in the limited spaces where Washington DC is going to allow us to operate. That's why I'm being so
Correct.
maniacally focused on this, because we don't get much room. We're stuck in so many ways watching healthcare expand in cost out of our control. Here's one of the few ways we can have some impact. So that's the reason
Correct.
I keep poking. But I hear you and I understand. Thank you.
Yeah, and if I can just end to that, I want to make sure that we're comfortable when we give you a number, and they, to their credit, want to be comfortable as well. And so they have a number of people working in analyzing data and prior claims, and we're working with them, and we're helping in times guiding them along that way. So when we come back in September, we feel comfortable that at least in the behavioral health area, you're going to get some real good numbers. We'll talk about the development disability area as well, Richard will. And that's really what a lot of today is about. The update on the PO enrollment we're going to talk about, we got some recent numbers from them for you. We've analyzed some of those numbers. You can get a chance to see what's going on there. I was hoping to get some claims update for you because we do have the all-payer claim database. We're still going through it. There's a lot of issues there that I've talked to the chairs about that we still need to scrutinize and cleanse the data to make sure whatever we report is accurate. We're going to talk about health insurance rates in general. We've had a lot of conversations and review and research, and we've got some information for you on that. The opioids issue is a big one. You know that. We talked about that. Rory has continued to look into this. He's contacted the state of New York. He's got some recent information for you. I think that would be really helpful. Sheila's been monitoring the EEF system update, the upgrades. She'll be able to report to you on that. And then Richard, if you remember, Chairman Hendren wanted us to meet with the department to really push this birch tree issue to make sure, is there an impact? There was a really great outcome that came out of that process. We're going to report on that. So that encompasses all of the reporting today. And I do want to emphasize, again, we're going to go as quickly as possible here. And I forgot the medically frail issue. We're definitely going to address that. We did a lot of research on the medically frail issue. This last meeting, you had a lot of questions and concerns about process. Stephen and I actually came here to meet with some of the folks. We've looked at the data. We've analyzed the department's process, and we'll be able to talk to you about that. And I think you're going to be comfortable with knowing and hearing what we found. And with that in mind, I'll start. So Richard is going to talk first about the behavioral health and the development disability initiatives. We have team members working with the department today, currently, and we'll continue to do that into September. Richard?
Thank you, John. I'm going to go through these slides as quickly and hopefully as transparently as I can. All the work we've done in the last month has taken place with the cooperation of DHS and Commissioner Gillespie, while the structural changes that Commissioner Gillespie shared with you several weeks ago are ongoing in terms of centralizing fiscal services and other shared services. That's important to keep in mind. They're going through dramatic organizational changes and task responsibility changes. So the amount of support that we received in the last month, Dr. Oliver and I have been here 3 times since the last task force for several days at each meeting with both BHS, specifically in terms of targeted code information, and DDS on savings. Since the last task force meeting, DHS successfully issued an RFI for the independent assessment, pre-authorization, utilization, and care management recommendations that we made and you adopted in the December report. They received 7 responses from across the board national organizations, and the department is moving as quickly as they can to move to the RFP stage. They've posted those RFI responses, and they're available to anyone who wants to see them. The one thing I would add is that all of the assessment instruments that we have recommended are embedded in the IT systems of the national respondents to the RFI, which means you don't have to pay for the redoing of the IT systems to implement those independent assessments. That's a critical factor. We are doing, as John said, national intelligence research and trying to find out the cost for this type of managed fee-for-service model. It's critically important that the task force and other members of the legislature understand that in order for DHS to make these savings, the rules and other aspects that impact law, if any, need to be passed by the end of this year if you're going to be able to go live July 1st of 2017. That includes changes to the RSPMI benefit to a new evidence-based practice model, and it includes changes eventually when DDS and DHS make final decisions on the HCBS waiver.
Okay, to that point, do you know, and I imagine we have someone here from DHS who may need to speak to this, but are we on track to do that? Have they been submitted to the appropriate legislative committees for review?
They'll have to answer the detail, but as far as our discussions with Commissioner Gillespie, they are on track to have this done by December of 2016. And as you said, I think the folks from DHS can respond to the specifics.
Okay.
And as John said, we'll have specific numbers for you on the DDS, the DBHS and the DDS savings. We've worked on the ground. The rules changes to the RSPMI benefit are critical. These are controversial. We're preaching to the choir. The Department in Behavioral Health has worked hard on this. I think they need to do a little bit of work in there, particularly around the patient-centered medical home. I think I would take a second look at that. But in general, I think they're in good shape to move forward. And they've been meeting with their stakeholders throughout, as I'm sure you would imagine. On slide 5, we have the specific constructions of what are recommended in big picture items. Includes the locus and cans recommendations on independent assessment for PA, utilization management, and ASO services. That's an increase in cost. the elimination of the paraprofessional and replacement with evidence-based practice for clients in tiers 2 and 3. That means they're moving to 3 levels of care: counseling levels of care for people with low needs for behavioral health care services. They do not require an independent assessment, and there are limits on those benefits, and beneficiaries can ask for an extension of benefits in that. Level 2s and 3s are the tier 2 and 3 are for populations that we would consider seriously and persistently mentally ill adults and children with serious emotional disturbance. They're replacing the psychiatric diagnostic assessment with an independent assessment. That should save on time and money. And they're going to reduce the dependence on residential treatment by targeting more effectively recovery-based services for people with serious and persistent mental illness. They're going to replace the master treatment plans for all but tier 2. They're going to add a therapeutic community benefit, which would address the Birch Tree issue, which we'll get into, and other providers that you have dealing with your 900 population, your forensics population, with a therapeutic community per diem benefit. And the cost of independent assessment, as we said earlier, is under review by us, and we'll be reporting back in September on what we find nationally.
So you're saying all of these items are in process right now of being implemented?
No, they're in process of being, they're articulated in proposed rules, or in the process at DHS of going through the preliminary process to get those proposed rules through the legislative process.
Okay.
I think they need to do a little bit more work on the evidence-based practice parts of it, particularly on the patient-centered medical home. We had recommended a PCMH, a patient-centered medical home for seriously and persistently mentally ill adults, using the Section 2278 ACA. I know ACA is a bad word, but this is a 90-10 match for 8. This is voluntary on states' parts, and you can get out of it after 8 quarters. You get 90-10 match for 8 quarters. The trade-off is cost savings in your medical care services. If you set this up and you don't save any money, you don't do it after the 8th quarter. If you set it up and you save money, you have a decision to make about whether or not you want to continue on a track of increasing appropriate medical care for people who ordinarily don't access medical care, correct? They go to emergency rooms or no care at all. And you do not identify this population for the PCMH model.
But if I can just add to Chairman's point, this is really their plan. And so we're trying to make sure this is the department's plan and not our plan or anyone's plan. And what we're trying to do is to move forward and help them aggressively meet your timelines. And that's what's going on right now. And we feel comfortable, but as soon as we don't feel comfortable, we would let the chairs know immediately. And everything right now is very collaborative, and all eyes are focused on, before you leave in December, to make sure these rule changes make it through the legislative process, and they would have to answer more than the timeline issues.
And John, specifically, when you say the legislative process, what you mean is the ALC meeting that happens in December and getting the rules and regs approved at that meeting. Is that specifically the key legislative?
I don't know all the exact, they'll have to answer that, but I know that the rules process here, because there's so many different committees, and I've reviewed that in the past, and I'm just relying on what they're telling me. They'll have to answer that directly.
Okay, I'm glad John
Okay,
named me in on
we
the
got-
patient-centered
yeah.
medical home. That was just a recommendation that we made, to be clear.
Okay, we've got 3 on the list here, so Senator Cooper, you're recognized.
Thank you, Mr. Chair. I'm trying to catch up with what you're saying here a little bit. You said the RFP, did I understand you to say you didn't have really any grip on yet what that would cost?
No, actually, we're looking at it right now. So here's what we're determining. There looks like there's about 25,000 serious persistent mental illness on a level 2 and 3 that Richard talks about. So we're trying to get it down to a cost per person. We've reached out to some of the other states. We're reaching out to national providers. We're trying to get the best estimate possible, because in your state, when you put an RFP out, you also have to have a budget item that is attached to that. So we will have that by the next meeting, when we'll feel comfortable.
Now, am I to understand that that maybe other states are not approaching the assessment the way that we are, and what's the approach there as far as federal guidelines?
I think if you give Richard time, he's going to go through that. We've got 3 slides that talk about the assessment process.
Okay. And one more thought. the cost of the RSP is something that's going to cost us money. And then, what is do you have the expected savings
That's,
of that? Yeah,
that's again going to be given to you in September.
in
It will
September.
be several millions of dollars.
Okay, okay, thank you.
And just to follow up on that, Senator Cooper, and for the task force, the Stephen Group has kept the targets that were in our recommendations in December for managed fee-for-service savings. So they're already listed, and that's about 25 million in behavioral health and 28 million in DD. Those are the targets that we've been working with. We're going to find out where they're going to end up on those targets by September.
Representative Farrar, you recognized.
Thank you, Mr. Chair. I think you answered this question, but I'm going to ask it anyway. I've seen slide 5, the last 3 meetings we've been in here. Do we have a hard deadline when that is going to be implemented at all?
We're going to ask DHS to give us a response to all of these things and tell us if the rules are drafted, the regs changes are drafted, and where they are in the process when they come and speak.
Well, I thought they'd answered it. Thank you.
Yeah.
That slide is important, Representative, to make sure we keep reiterating it so it doesn't change.
Actually, that's the 3rd time
Well, and it's a good point, and that's why, again, is, you know, we're telling DHS what the question's going to be before they get here, but we need to know, because we've got, 3 more meetings of ALC, and it has to go through public health prior to that, or some of them maybe through rules and regs or whatever. We need to know where we are on this. Because, again, the point that I went back to is a slide previous to this, which said it's critical that these rules be implemented in time for the July 1, 2017, if we're going to achieve those savings.
And it just seems to me we're just a little behind for some
Well,
reason. Well, I'll ask the question.
Yeah, okay. Senator Chesterfield, you recognize.
Thank you, Mr. Chair. I'm looking at the change description, and I'm wondering how you eliminate the intervention by mental health paraprofessionals. What does that mean? That they're no longer needed, that they were doing something untoward? How is this going to get us to a better interaction for our clients in tiers 2 and 3?
Thank you for that question. I should have added that the department is intending to add a service called Certified Peer Specialists, and I think that in lieu of this service, and I think that would be a good question for the department to explain what they mean by that. But basically, this is taking the certification process for peer counseling-oriented services to work with other people that have serious and persistent mental illness, and it is an evidence-based practice.
And this eliminates the mental health paraprofessional.
Yeah, that's their intention, and they expect a trade-off in terms of the utilization, current utilization of the mental health paraprofessional and the future utilization of certified peer specialists now that they're going to have 3 levels of care.
Could you define what a peer specialist is, and how many have you found out in your studies do we have in the state of Arkansas?
Peer specialists are essentially people, adults who have had and have lived with and continue to live with a serious and persistent mental illness, who have stabilized in the community and are working on a life plan, and part of that life plan is to assist other people with serious and persistent mental illness who are not as far along in their recovery as they are, and there is a certification process that each state can engender to bring that level of service up to a certified peer specialist. And there is a toolkit, if you will, that is based on evidence to engender that training to become certified peer specialists. It's used around the country. There are many states that use this, and this particular benefit over the years has been generated by the fact that Medicaid in many states wouldn't pay for this in the past because there was no certification process. And so Medicaid programs have worked with their behavioral health programs in states regardless of their structure and have developed this model, and there's a code for it. You'll have to ask the department how many there are now and what their plan for training is, ma'am.
So this is a certification process, and there
Yes.
is.
It's not onerous in terms of time. Depending on the individual, it can be a relatively straightforward process or a challenge. But it is not an expensive certification process either.
So, Richard, in actuality, what I need to do is to ask them, since these are their plans, not suggestions from you guys.
That is correct, ma'am.
Okay.
Thank you.
Well, I'll let you off the hot seat then.
Well,
Thank you.
Okay.
Next one.
Okay, slide 6 on process. What we've been doing with BHS and the Department of IT people is working at the code level to get baseline at the code level per person for 2014-15 costs, which we have pretty much achieved with great assistance from the department and the Department of Behavioral Health Services people. And we crosswalked, Will and I met with DBHS just last week for a whole day, and we crosswalked the new benefits package that they're going to bring to you for approval in rules, and crosswalk potential utilization in the new benefits and compare them in the crosswalk to the old benefits and the old costs. We're at the point now where they have come out with a raw set of data that's really not available to go live anywhere, and we need to work on that to refine it. So we're going to be doing that between now and the end, between now and the next task force meeting to try to confirm the savings and confirm the assumptions that the department has done. If you go to slide 7, you can see that the model is in the process of being recasted on the utilization side of the new benefits. And we hope to be having that completed here in the next week or two. That would be what we would consider a financial modeling of old benefits to new benefits to predict either increased cost or decreased cost. We anticipate, and the target is to decrease costs overall and improve the connection of people's level of care with evidence-based practices in the new benefit construction. Moving to slide 8, we've met several times with DDS. They have been working closely with their stakeholders, particularly on the DDTSC and CHMS services, particularly OTPT and ST. They have, from what I understand, have reached tentative agreement on changes to those benefits in terms of scope and duration, which had been recommendations made by the providers themselves that we endorsed at the December meeting of the task force. And they have some preliminary savings on that. As John said, they're not ready to go live. We have had some challenges in developing a crosswalk between the current waiver and a potential new waiver for a couple of reasons. One, I think that there's still, DHS is still in the process of determining the levels of care, how many levels of care that they are going to support in a new waiver. I think there's been recognition that the actual services in the current DD home and community-based services waiver for adults will pretty much be, if not 100%, 99% the same. I'll give them a little wiggle room, but pretty much will be the same in the new waiver, if you will. The thing that will be new in the new waiver will be independent assessment based on the SIS and individual plans of care and budget and levels of care by tier attached to cost. Those will be the major changes. And we hope to have more information back to you, and we will have final recommendations on savings at the September meeting. But it has been somewhat of a challenge on the data, and I think this is part of the transition process that I mentioned early on. And also that the department is, frankly, entering into the era of doing financial modeling in its first generation. Slide 9 pretty much just it shows what I just said about what they're working on and what the changes will be. Going to slide 10 real quickly, we've recommended the LOCUS as it's a level of care instrument for adult behavioral health. It's 16 pages. 16 pages sounds like a lot. There are domains on each page, and it's a checklist orientation for the individual clinician who's doing the interview with the client. It provides multi-dimensional assessments. This is critical. It involves daily living, it involves symptoms, it involves functioning, it involves social factors and environmental factors. The instrument is embedded, as I said, in all the IT systems of the RFI respondents that do this on a national level, and it is used pervasively in many state systems. It's a product of the American Academy of Community Psychiatrists. It's always under review. It's been normed, and it's public domain, which is no charge to the state to use. It also has a navigator associated with it, which is probably a little bit too much detail, that allows a clinician who's actually providing the services to track it for changes in conditions, to redo the locus so that the services plan is appropriate as the individualized budget and the cost. Moving on, if there aren't any questions about that, slide 11 on the cans. This is an assessment instrument for children 5 to 17. It's also public domain, supported by the Parade Foundation, also in connection with the University of Chicago at a section of the University of Chicago. It's used in 50 states for child welfare, mental health, juvenile justice, and early intervention. It is currently used by your child welfare system in Arkansas. The tool has 42 questions. They're designed to assess the child's family environment that measure risk, behaviors, emotions, and child functioning. The needs are assessed on a scale of no evidence, prevention, monitoring, and action, meaning plans are needed. It's a relatively simple, normed instrument that a trained clinician can deliver. And also, this is also an instrument that is redone on a timely basis based on change in condition. The SIS is a system developed by the American Association of Intellectual and Developmental Disabilities, is currently used in 24 states. It's been designed and tested to evaluate and measure practical support needs of an individual with intellectual and developmental disabilities in daily life functioning. It's administered by a team, one person, a family member, a guardian, or a chosen loved one needs to be there with the individual to support that person and answer for people who are unable to speak for themselves. It's an 8-page interview that measures 87 areas, and you can see the detail of what that is. The professionals need at least a 4-year degree in training with state-identified qualifications, and there's a 128-page manual to help. There are no right or wrong responses. This is pretty much an instrument that measures how a person experiences their day and what supports they need. It also deals with employment, and it deals with social factors, and deals with environmental factors and health and safety factors.
Okay, we've got a question. Representative Sullivan, you're recognized.
Thank you, Mr. Chair. I'm over on this side over here, gentlemen. Just when we heard the same kind of presentation several years ago when we started the Inter-RAI, that it was used in states and it was used internationally, and that it would come up with cost savings. I think we've been at that 3 years, and we still don't have any success at it. So my question to you is, when you give us a cost analysis, will you share with us or consider the failure we've had in trying to do this statewide previously? And will you also share, and probably a more important factor is, there's a cost benefit. So we implement this, and there's a cost to implement it versus the savings that will be realized. Will we have that number?
I can address that. Yes, we were not going to be looking at the past failures. That's an additional task. If the chairs want us to do that, we can. But we're definitely going forward and trying to identify what it's going to cost in terms of IT connectivity, all that stuff.
Just one short follow-up. I can appreciate not looking back, but I guess maybe then the question is, what's the risk of this not succeeding either? There has to be a risk factor in this, us not being able to implement it.
That's a great question. The method that we've recommended, and DHS has already gone down, is through the RFI. So the risk here is the state contracts with a vendor to do this. I think the RFP should require that they have the IT infrastructure to do the SIS and the other assessment instruments so that there's no cost to the state on the IT side. It's part of the contract. The contract should be a performance-based contract, and if the vendor doesn't deliver, there should be a penalty or liquidated damages, or the contract should end.
But, I mean, I just want to be clear. Historically, there's been some issues, and you're absolutely correct. I mean, that takes a lot of, review and why it happened and what the issues are, but I think the department is very cognizant of that. And when we've been meeting with them, we're trying to look forward to make sure that they put the appropriate number of dollars in here so we don't overestimate savings for you, and we're going to do the best we can.
John, how often is this assessment done?
Annual basis or changing condition. The SIS in some states have moved to 3 years or 2 years, mainly because of the trajectory of people with intellectual and developmental disabilities in terms of need for supports on a day-to-day basis. So that's a decision the state can make.
Does that answer your question, Representative? Okay. So moving on, if there's no other questions, you can see there's a lot of work there going on. Those are two key areas. And Representative Collins mentioned the memorandum of understanding with long-term care. You'll hear probably more about that today. But now the patient-centered medical home is for the lower cost, but there's also some high-cost individuals that are not in those other systems that we're going to talk about today real briefly. Stephen's going to go through it.
So we're starting here on slide 13 of the deck. This is just an update on the patient-centered medical home with some opportunities for potential enhancement or increasing the cost impact. I'm not going to go through this in very much detail. On this slide, the two things that I would call out are that just some program features that in order to participate, a practice must have at least 300 Medicaid beneficiaries. And then the final bullet, that certain costs and populations are excluded for the purpose of calculating the savings. On the next slide, it gives some progress of the PCMH over the 3 years that it's been in place. What I would call it here is the final row towards the right-hand side. The number of beneficiaries currently is projected for 2016 to be about 330,000 out of a potential eligible 414,000 for about making up about 80% of that pool. The important point there is that the denominator there is the number of eligible beneficiaries, not the total number of Medicaid beneficiaries. And that's due to in large part, that 300 beneficiary cutoff for participation. The next slide shows some actual financials for 2015. The estimated raw cost for that population was a little over 900 million, but the total cost of care, that is the total cost that was included for the purposes of calculating savings, was about 660 million. So you can see there's a gap there of a couple hundred million. Those are services that are being provided to individuals who are in the PCMH program, but those are costs that are excluded for the purpose of calculating savings. Overall, the net savings is about a little over 2% against the projected for that population. On the next slide, I have several different potential program changes that could have an impact on that overall savings. Here, I just estimate an impact of 25% on several different program changes. The first is increasing the number of beneficiaries covered by 25%. Largely, I think the biggest factor to drive that would be lowering the required number of Medicaid beneficiaries per practice. Then increasing the effectiveness of the PCMH program by giving information about episodes of care to the PCMHs that would allow them to direct their patients toward lower cost providers, and then increasing the services being managed by pulling in some of the lower acuity behavioral health, which is largely excluded currently. On the next slide, I have some estimates of what those changes would do to the overall estimated savings. And taken together, I estimate that it would increase the savings by an additional almost 10 million per year.
And what changes are required, and are there any statutory changes required for this, or is this all done by regulation?
I believe that it could all be done either by regulation and policy, but it might require some approval from CMS.
And what is where's the department at on working on these things?
These are still largely at the discussion stage. No decisions have been made to go forward with these changes.
Okay. And again, that's one, whoever's going to be speaking for the department after lunch, I'd like you to be prepared to kind of give us an update on where we are on taking these from the talking stage to the actual changes. Okay. Do you have anything else on, before you move to medically frail members, I visited with the co-chair, and what I'd like to do, if there's not objection, is go ahead and let you guys take a break, because we've got the insurance commissioner here to give a report, and so he didn't have to come back after lunch. I'd like to get him in before lunch. I know he's got a department to run over there, so why don't you guys, we'll pick up there probably after the lunch break, but Commissioner Kerr, if you'd come down, we're going to go ahead and skip to item E in the agenda. Well, welcome back. We appreciate you making yourself available. If you just state your name for the record, you're recognized.
I'm Alan Kerr, Insurance Commissioner. Thank you for having me here this morning. I appreciate the opportunity.
So do you have any remarks, or you just want some questions?
We'll take some questions. I want to start out by just kind of briefly taking everyone through the rate filing process and kind of let you know how that goes. About in May, the insurance companies will submit their applications for rate changes or rate increases and sometimes decreases. What we do at that point is we go through, they supply those electronically, and then we go through those and look at their reasoning. We go to work and we contact an outside actuary. We go through a pretty exhaustive process in the evaluation of these rate requests. We will have an outside actuary. We will, in fact, we contacted the actuary from DHS. We even contact actuaries from other states to run the information by them. But we go through a pretty deep dive into these processes, and what we try to do is come up with after we crunch all the numbers, we try to come up with a working rate that will work for the insurance company as well as the people of Arkansas. And we take a lot of things into consideration. We take surplus, we take their claims, of course, and a lot of details goes into this, and we come up with a compromise. And it almost always happens. Nobody's happy, but we hope we come up with something that's workable and palatable for the state of Arkansas.
Okay, Representative Farrar, you're recognized for a question.
Thank you. Representative Commissioner, has Blue Cross Blue Shield given you their actual claims data to come up with a price increase or premium increase?
That would be a question for the actuary. The actuary does look at their claims data, yes.
Okay. Okay, so they've given, they're called the 85 MLR, 85-15 MLR ratings to them,
Yes, sir.
as you know. Do you think they have, or do you know for sure?
I'm sorry, what was the question?
Have they given the information, the actual cost, the 85-15 MLR, have they given it to your actuarials?
Yes.
They give you that information?
Yes, sir.
Okay, thank you.
I know in the comments that were in the media that there were statements that this is a one-year reprieve, that there's no way they can live with this type of margin moving forward. I guess what I would ask you is, do you have concern that we're setting ourselves up for a larger increase in 2018?
18, yes,
Right.
sir. Well, yes and no. I mean, whatever rate we don't take this year, if we make no changes at all, if we make no corrections, course corrections at all, then yes, we're looking probably at a larger rate increase next year. As a rule, as history has shown us, Arkansas tends to move about a year behind the rest of the country in economic downturns and things like insurance rates. So to answer your question, yes, sir, we may be putting this off for another year. But what that does is that gives us something that's palatable and something that's affordable for the next 12 months while we make these course corrections and hopefully come up with a better plan.
As you've had discussions with your colleagues in other states, are they seeing similar type of situations, or particularly, do you have any communication with other states that have done private insurance plans for the expansion and how it's worked for them?
I don't know of any other state that has done a system quite like ours, but in states whose systems are similar, yes. I mean, they've had double-digit rate increases. I mean, just the states around us, just to name a few, Alabama, for instance, is looking at a 39.3% increase. Mississippi, 32% increase. Missouri, 34. Tennessee, 54. Texas, 57. So there's a lot of activity going on around us,
But those are policies on the marketplace.
Yes, sir.
Right.
Yes, sir.
And what is our increase going to be on our marketplace policies?
With Blue Cross, it's going to be 9.7.
And that for both the marketplace and the exchange?
Yes, sir.
Yeah, okay. Do you have a question?
Yeah, so, again, I'm too dumb to look at the little tiny pieces, so I'm gonna give you my view of what happened. DC said, we're gonna give free health care out. We used to subsidize it in the emergency rooms with EMTALA. We're gonna pull those subsidies away, and we're now gonna do it by giving you your Medicaid taxes back. When we do that, we're always gonna make the same assumption, just like if you ran a free buffet. Before it was free, Jimmy ate 2 hamburgers, and we're going to say, now that it's free, Jimmy can probably only stuff down 1 more hamburger. It never works that way. Jimmy brings a suitcase and sticks 500 hamburgers in the suitcase, and somehow Jimmy goes from when he had to pay buying 2 hamburgers to now having 502 hamburgers, and we're stunned that it's 50% increases or 100% increases or whatever it is. So the reality is that was put in motion by Washington, D.C. nationwide. We cannot control it. The second thing they did was they said insurance companies will not be allowed to profit from this because we're going to make a new law which says however much they collect, they must spend 80% or 85, whatever the number is, and their profit is limited. So an insurance company could raise the rate 50%, 90%, 100%, and their profit margins are not allowed to expand legally. So even the incentive, as greedy as they are, none of the rest of us are greedy, just them. But as greedy as they are, unlike the rest of us, that won't work for them. And the reason it won't work is because the same law that said it's all going to be free also said you can't raise your margins. So here's my biggest concern. If we go to Washington and we tell them, look, even though it costs 50% more in Texas, 50% more in Mississippi, 50% more in Tennessee, we've got some magic pixie dust in Arkansas where we can do all this for only 10% more. And I now promise you, Washington, because our private option reimbursement rates are based on annual changes off of a base rate, that we can somehow magically do in little old Arkansas what they can't do in Texas, they can't do in Mississippi, they can't do in Tennessee, they can't do it anywhere else. But just here, we have magic pixie dust that it's going to blow up in our faces, and 3 years from now or 2 years from now, we're all going to be looking at each other wondering how we got here. So are we setting ourselves up for that with the Washington, D.C. commitments? Because if we are, is there any way that we can undo that? Because I fear it could be really challenging.
Well, first there's a lot of stuff in there. None of these companies, if they could get to 80%, they'd be tickled to death, okay? A lot of them are tracking at 90, 95. Because of that, a lot of these companies are pulling out of these other states. I'm going to be more concerned about having someone to offer insurance in Arkansas. If they can't make a profit, they're going to pull out of that particular market. United Healthcare already has. So to think that it won't happen here is, well, it would be irresponsible. But the bottom line is we have the opportunity, we have another year to make these corrections. And whatever Washington sets up for us, we have to come up with a counteraction.
Can you give me an idea of some of the corrections that we could make?
Well, and you've already talked about them. The medically frail is an issue. The retro terminations, the insurance companies are still waiting for payments back on those. And the fact that there are no limitations to, like you said, use the hamburger analogy, there's no limitations there. They can go to the emergency room as many times as they want with these contracts.
I watched Senator Hendren with a very fancy PowerPoint walk through the concept of people shouldn't be allowed to have 392 hamburgers just to throw them down in the sewer when they walk out. I watched the response in D.C.
Yeah.
they like it. They're going to keep pushing it. Now, maybe something changes in DC, but boy, oh boy, that sure is betting on the come.
Yeah.
Members, just for clarification, you've just gotten a handout. I asked John as we got ready for this meeting to try to pull together the rate increases in other states, so you'd have something else to look at. Commissioner Kerr, I think you have that as well.
Yes, sir.
And so it's a good point of reference. One thing, and I don't know whether we need to have John or some of his people answer this or not. I'm not quite certain whether this is all finalized yet. For instance, in Arkansas, it's still showing 15.1 when it was 9.7. Or
No,
whether
sir, I
this-
believe these are requested rates, not final rates.
So like in Oklahoma, are they really likely to get a 51% increase?
Well, considering Oklahoma has one insurance company left in the marketplace, probably so. They may get 45. They may not get 51, but they'll probably get 45.
And that's for all the policies on the exchange, insurance
sir.
marketplace?
Yes, sir.
Okay, we've got 3 on the list here, and again, I know this, if you have questions about this chart, because again, I wanted people to be able to have a comparison to where we are in other states, you may want to let John come and speak to that after we get done with Commissioner Kerr. Senator Rapert, you're recognized.
Thank you, Mr. Chairman. Commissioner, whatever the rate increase is it not true that this also affects people that are buying this without any subsidy or help off of an exchange?
Yes, sir. This rate increase is going to affect everyone. I mean, whether they're buying on the exchange, because the insurance companies have to offer the same policies, the same contracts on the exchange as they offer off the exchange. And not only those who are buying these policies, are individual policies, but as taxpayers, as you know, this year we're going to have to pay a percentage of, Arkansas is going to have to pay a percentage of this out of the Arkansas pocket. So an increase to rates here means an increase to rates there of what Arkansas is going to pay out. So for these policies that Blue Cross is selling, Arkansas will end up having to pay now, instead of 14.7, a 9.7 increase.
So is it fair to say that for those individuals that are buying the private policies, we're going to assume they're taxpayers as well?
Yes.
So we are paying, some would say we're spending more tax money to subsidize other people that are causing the rates to be increased, and then the private individuals are also paying higher premiums.
Yes, sir, I cannot disagree with that.
Okay. Obviously, I'm going to withhold further comment on that because I could really get anointed, as they say, on that particular issue. It's a big problem.
Yes, sir, it is.
But I also want to mention that this list Mr. Chairman, this list that's been handed out, I know it's a list that's been pulled together by the Stephen Group, but it's very interesting. At the bottom, the footnote says this is from ACA Signups, an amateur website. I have a hard time us trying to make decisions and talk about information that's from an amateur website. I just would say I would love to have a whole lot more solid information than I would.
Well, again,
with
in
that.
their defense, I gave them, I think I told them this Friday afternoon, so I didn't give them a lot of time to go do a lot of research.
But as we see, there's some numbers. I know that they got it quickly, but I'm just saying we're going to have better information than an amateur website to make these decisions.
I can tell you for a fact, I got a note from the insurance commissioner in Alabama that they did give their major carrier there a right at a 40% increase. And his response to me was, we had no choice. So, I mean, if you look at this list, where Arkansas is going to end up in the bottom 5 as far as rates go. So that's a good place to be.
I guess to echo maybe a little bit of what Chairman Collins was saying, I know what Washington says and what Washington thinks, but we're fast approaching a point at which the states may end up having to really consider just saying no to some of these other issues. Now, I know that we could get off on some different things, but the fact is that regardless of what Washington says and what Washington wants, the reality is that the costs are spiraling out of control. And we have taxpayers that are paying not only for the cost of providing coverage, but they're also paying more for their own premiums. And in fact, some of those people may end up being uninsured. So it's a real conundrum, it's a problem, and I think we all can agree on that. I just wonder when we all are going to get the resolve to just band together and say, we're not going to do this anymore.
Here's the one challenge, because I'm with you on that. The one challenge is that we passed a law in 1986, which opened up the emergency room, so anybody, anytime, any place, anywhere, for any reason, can move in. And the feds used to subsidize some of that. And what DC has done is they said, we're no longer going to do that. So we can pull the rug out from anybody we want in terms of insurance and programs, and the emergency rooms are just going to fill up, is what I'm fearful of. That's the reason that people that have said no to Medicaid expansion, like Alabama, are still seeing 40% increases. That decision is not what's driving this. DC's driving it through a host of issues.
That's true, and I want to just say, because we can discuss this more later, one bad decision is not justified by another bad decision. And what we have here is a situation where the people that are paying the taxes that is underwriting and funding the extension of this coverage is now driving up their premium costs and putting them in a position where they can't afford it. And I think it's insane. And so, you know, I have done my best personally to do what I can to support policies that we're being forced to undertake. But there's a point at which I think it tests the resolve of any of us to support something that is so insane as what is happening right here. And again, I want to stop because I know that's a debate for another time, but I just want to say to you, as I've been through this process and we're still dealing with these issues, there's a point at which this is really testing all logic. And so it's a problem that we have to look seriously at in the future. Thank you.
It's called free stuff, Senator, free stuff.
Senator Irvin, you recognize.
Thank you. I have a quick question over here. Hi.
Hi.
Quick question on the medical loss ratio. I recall that some of the companies actually did have to pay us money back. Is that correct? Was that factored into the rate increase request? Because of the medical loss ratio, they actually owed money back to the state.
Yes,
and
Senator.
so I'm trying to square all of that. I'm trying to square the fact that we had enough, you know, there was the premiums that we were paid in excess, where actually they had to pay money back to the state because of the medical loss ratio formula, but now there's a rate increase. So I have trouble squaring those two things, and I would appreciate your response on that. And then the second thing is, you know, when we went through the program and why we decided to expand the Medicaid population utilizing private insurance was to try to drive down premium rises and rates, drive premium rates down. Big selling point, you know, back when the private option was being sold, basically, that this would enter into the marketplace, you'd have a larger pool, and this would help drive the cost of those premiums down. But with these rate increases, is that necessarily the case or not? So I want to hear your response on that. And moving forward, this might be a question more for the Stephen Group, is this the right thing to do with this population? Because if we're moving medically frail out of the pool, that's going to be more cumbersome on the state as far as our raw costs, and it may, you know, keep the premiums lower because you're moving those medically frail people out. But, you know, where's the balance there with this population? Are we going to save more by doing that, or are we going to incur more cost, just raw cost, if we do that? And then, you know, what I don't want are two different systems for the same population, where we're having the private insurance for this group, but we're having to do something completely different with this group. And it just seems like efficiency would dictate, you know, what do we do in the future with this population? Do we keep them in the private insurance market, or do we move them out entirely? Right now, we're piecemealing. And so, you know, I'm looking for the future fix, because as Senator Raper said, you know, it's difficult to control these rate increases because we're dependent on the private companies there that are supplying these. So three different questions there. If you can attack them, I would appreciate it.
Well, let's take the last one first. First of all, you're absolutely correct. That's more of a question for the Stevens Group. From what we've seen, from what I've seen in the years I've been in insurance, you would think by putting everyone into one pool, it would be better, you get a better result. You almost never do in insurance. It's going to be much better to be able to treat one segment differently from another. And the reason for that is that they have a different mindset. In other words, they do tend to abuse services and those kind of things if they're not paying a lot for it. But that's about all I can comment on that. The Stevens Group would be a better source. To address your question about medical loss ratio, there's one company that isn't in all the markets, but they're in a segment of it, which is Celtic, Centene, and Better. They have several sub-names, but they're doing it very well. They are tracking around a 79-80% loss ratio, and they did, in fact, give money back. We took that in consideration. I'm not in the habit of, if AT&T calls me up and says, look, if you let me have this rate increase, if we overshoot it, I'm going to give you your money back next year. That almost never happens. But we did take that into consideration. They asked for an 8.1% rate increase. They very well laid their case out and could justify it very easily. I had an actuary who used a little bit of different spin on it and said that they should have a maximum of 4% increase, and that was where we kept their increase. My actuary tends to look retroactively at what the experience has been. Insurance companies most often want to try to project things, okay? So we took kind of a middle-of-the-road approach with that, to be fair to the insurance company. And a 4% increase is something you're not going to notice it much. And we thought that was fair. We love the fact that they give money back to us, but at the same time, I'd rather not spend it to start with. Okay?
Well, because they're able to gain interest on that money if they're keeping it, which, I mean, you know, I would rather it be in our coffers
I
instead of
agree.
theirs.
I agree.
So, from the onset,
I
yeah.
couldn't agree more. The second question was about population and whether this program actually does help. I think, I don't know, look at the other states. I think it is helping to some extent. I'm no expert on it. All I do is drill down at insurance companies and look at rates. But from the experience that we're looking at so far, Arkansas is doing a little better rate-wise. So now what's happened is this population that everybody thought was, again, by throwing everybody together, they think that more people in a pool gives you more profit. It does not. This population has a lot of deferred maintenance, so to speak. And you know, in your clinic, you've seen it. Everybody thought that it's a younger population and we can add the young people in there. Well, some of these people are obese. They've got onset childhood diabetes. They've got Hep C. Some of them were born with it. So it's a lot of deferred maintenance and a lot of this on this population. And just my personal opinion, I'm hoping that it will crest after we get them all back to baseline, and it will level off and ease off. We don't know. We're yet to see that.
Yeah, okay, yeah. No, I appreciate that. I think I agree, and thank you for the questions, because I think it was a lot of a guessing game as to what this population looked like, what their health issues were, and it was a little bit of a guessing game. And now we have some data that we can really look at to make some better decisions, perhaps moving forward. Is this the correct place for these individuals to get the care that they need, not necessarily, you know, the all-service buffet? Thank you.
Yes.
Representative Boyd, you're recognized.
Commissioner Kerr.
Good morning.
Good morning. I'm really not sure how to ask this. I've just been kind of thinking this through as we've been here, so I'm just going to kind of start with what I'm trying to understand.
Okay, just
And
throw
so
it at me.
I'll start there, and then I've got a couple questions that might help me understand, but anything you can add to it that helps me. So really what I'm trying to understand is my understanding of the reason we go this route where we're using insurance companies is because it introduces competition into the marketplace. And so I guess question number one is, when you say, okay, well, people are going to pack up and leave if we don't do these rate increases, it sounds like maybe there's not competition. So that's question number one. Then number two is, how many insurance companies are registered in Arkansas versus, nationally? I mean, is there something we're not doing as a state to encourage competition, or is it just there aren't enough insurance companies, so there is no competition? Any insight into that would be appreciated.
All right, sir. There are 3 companies, used to be 4, in this particular market. Qual Choice, who has just put their individual policies and actually their whole company, CHI, Catholic Health Initiative, owns Qual Choice. They've put them up for sale. Okay? They're not making a profit. This is a losing proposition for them. And CHI has figured out that they're better at running hospitals and the like rather than insurance companies. So they've got them up for sale. So they're kind of teetering. UHC, United Healthcare, has left this particular market and no longer, and they've left this market in several states. Aetna, who I was talking to, hoping to bring them into this market, just announced a week ago that they were pulling out of this market in several states, many states. So you're left with Blue Cross. Humana, who doesn't do a lot of business in this state, has pulled out in 4 of the states that I listed here. Aetna has pulled out. So you're looking at a mass exodus rather than somebody wanting to come in and do business here. I don't think it's anything in particular that they don't like in Arkansas, so they're not really picking on us. The only thing I could go to that draws any insurance company in is that we have a relatively high premium tax rate here as opposed to some other states, and that's not real attractive to a company wanting to come in and do business. But what they look for is, can they come in and do business and make a profit in Arkansas? Workers' comp, for instance, we'll just use that as an example. Workers' comp in Arkansas is probably the best thing Arkansas has got going insurance-wise. It is the lowest here than it is anywhere in the country. Our work comp rates are extremely low. So a lot of companies, insurance companies that generally don't sell that type of insurance are commonly wanting to come into the work comp market because they know they can make a profit at it. Just in the last 12 months, we've had about 12 companies get a certificate of authority to do work comp business. So again, what attracts a company to do business? It's profit. Can they make any money? In this particular market, they're not making money anywhere. So to answer your question, if there was competition, if there was a way to make money, then you wouldn't have any problems. If there was a way they could do it right. If they could manage those claims, if they could segment those claims, some way that they could keep the cost from just running away. But we don't have that here. So it's not real attractive. So the best we're trying to do is keep it as close to a workable rate as we can and still make it attractive for them to stay in the market that they're already in. Does that answer your question?
I think so.
All right.
Thank you.
Thank you, sir.
Representative Farrar, you're recognized.
Thank you. I have a simple question. Does the 9.7% increase, does it keep us under budget neutrality?
I'm sorry?
Does the 9.7 increase keep us under budget neutrality from the feds?
Yes, sir, it does.
It does. How close are we to the cap?
Very close.
Do you,
A hair's breadth.
any two? I mean,
0.00 something.
okay, so if we're real close to the cap, and next year the cap's supposed to go up 3%, if I remember my numbers right, we'll be above the cap next year.
Depending on how the rates come in, yes, sir.
Well,
I mean, it could go either way.
We go by past history. We've
Right.
had 7 and 9, and before hair's close.
Yes, sir.
Next year, we can't get it increased, about 3%. and we're not gonna get a 3% increase next year. You've said it yourself.
Right.
What do we do? Because we'll have to pay the money back. I mean, I'm just looking ahead.
Well, again, we were focused on this year,
Yeah.
trying to get this behind us, and then, you
Government
know,
only goes
and it
one.
never fails.
Go three.
It never fails, Representative, rules change from year to year. They're different, they're a lot different this year than they were last year.
So, Alan, building on what Representative Fryer is saying, if the feds chose not to adjust, right, because they set unrealistic, if everybody on here is at 30 or 50%, then saying you can only grow 5%, and other than that is budget neutrality, what they're really saying is, we don't want a private market, we want to force you into straight-up Medicaid, because if we did straight-up Medicaid, it can go up 1,000,000%, and they're fine paying that all day long, correct?
That's correct.
Good.
I figured.
And I think this is what some of us said 3 years ago, what's kind of basically coming true, what's going on now. So, thank you.
Representative Miller, you recognize.
Thank you, Mr. Chair. I guess just kind of ride in on the coattails of Senator Rapert's anointing a minute ago with his questions. I have this, do we have, Commissioner Curd, do we have a dollar figure amount since 2013 when the private option was implemented? Do we have a dollar figure amount on how much private insurance, folks who are taxpayers that pay their own private insurance, how much their insurance has gone up since 2013? That's the first part of my question. Do we have any access of getting that information?
I could probably get it for you, sir. I may have to check with the Stevens Group or some of our actuaries, but yes, sir, I can get it for you.
Hey, I would really appreciate that. And then the second part of my question is, because of what you were just commenting on about the companies looking at us and wanting to make a profit and all that kind of stuff, in the next 3 years, or 3.5, or whatever, by 2020, do you see a scenario playing out where the state of Arkansas cannot attract insurance companies to come in and want to serve our Medicaid expansion population?
Well, sir, that is a pretty wide open question. I have no idea what the rules are going to be in 2020. Like I said, they tend to change on an annual basis. We don't know what the administration is going to be like in 2020. So, you know.
Well, let's say we have the same rules that we have right now.
Mm-hmm.
I mean, with what we're dealing with right now, are we looking at unless we make significant changes, are we not going to be able to attract companies to serve this population? Or just kind of what are your thoughts on that?
You know, it all depends on how bad they are in other states. You know, how bad are they in other states where they don't have what we've got? So, you know, there's a lot of variables in there to look at. I'm hoping that we can keep the companies we got and we can improve things to the point where we can attract some other companies by that point in time. That's a long time off. And surely we can make some changes, some course adjustments where we can attract some other companies.
Thank you very much.
Hey, Alan, I just want to, I stand corrected, somebody corrected me that we have an ability to ask CMS to change our waiver amount. And so until they reject that, my projection that we get forced off is way premature to say. They would have to reject our request for increases before that could happen. So thank you for correcting me, the person that corrected me.
And I guess I would just add to Representative Miller's question, and I think maybe this is for the Stevens Group. I know we've seen some of this data before, but the chart that you've presented gives us the requested increases for the exchange policies and so on. What I'd like to see is also a comparison on what has happened to private insurance rates on states that have expanded versus states that have not. What's been the impact? I think I know what the impact's been, but I would like to maybe see how that compares. Senator Chesterfield, you're recognized.
Thank you, Mr. Chair. it would stand to reason that if you had 250,000 people who've never had health insurance, that the cost of health insurance would go up. Would that be about a correct assessment, Mr. Kerr?
As we've seen historically for the last 3 years, yes.
If I've never had health insurance before and I get to go to the doctor for the first time ever with diseases or conditions that have festered for years, my costs are going to go up. If, however, I stay with that doctor for a period of time, should not the premiums then, or should not the cost of care begin to go down because the initial cost is invariably higher than the costs that come after? Would that make sense to you?
Yes, ma'am, and that's what I was trying to explain a while ago, is when you first go in and evaluate it, they're gonna have to run some tests to see what's wrong with you and so forth. And then once they have that baseline, it's a maintenance situation from that point on. That's why I said I called it deferred maintenance, because for whatever your problems were, you were unaware of them, in denial, whatever the case may be. And after that point, it may be a small medication, something along those lines to keep you straight. I mean, you may have a blood pressure problem, for instance, and that may be causing a lot of other issues. I'm not a doctor, but I've got blood pressure, so I can tell you from experience. It may be causing a lot of other issues, and then once you're on a medication, and most of those are not very expensive, then those issues level out and you don't have them anymore. So just a maintenance situation can solve a lot of problems.
Are we, or the Stephen Group, keeping tabs on where we were when we started? And on a year-by-year basis, seeing what is going on, so that in the next 2 to 3 years, we will know whether or not we've been successful to some extent?
I cannot speak for the Stevens Group, but from the information that I have, yes, they are. Depending on how long you retain them, will determine how long they feed you that information.
All right, thank you so much, Mr. Chair.
welcome.
Thank you, Mr. Chair.
Okay, members, that's all we have on the list. Commissioner Kerr, if you don't have anything to add, I want to thank you for coming over and making yourself available and giving us some insight onto this minefield that we're all trying to walk through.
Thank you, Mr. Chairman. Thank you, committee.
And I think we have an announcement.
Yeah, as Kelly Link here and Lori, we'll just recognize you at the table very, very briefly, just for an announcement and an introduction. And if you just want to state your names and your roles for the record, we'll just, and the good news is, we're eating into your time, so how long this takes?
We'll be incredibly brief, Mr. Chair. Thank you. Kelly Link, the Chief of Legislative Affairs for the Department of Human Services.
Good morning. I'm Lori McDonald. I'm with the Office of Constituent Services with the Department of Human Services.
And Chairman Collins, I think you want to say a few words.
Yeah, so the reason I asked Lori to come today is she has taken over the liaison work for constituent questions and issues with regard to health plans and other things in relation to us as legislators. And I just wanted to say it's been just a real pleasure to work with her. I wanted people to have a face to go with the name and the role, particularly for the legislators that are here. But now, when I get those questions, and I get a ton of them for some reason, Lori is so good about the follow-up, and there's one person, and she can connect all the dots. It actually, she really helps make us look like heroes to constituents who have questions about health care. Lori, I don't know if there's anything you want to say or not, but if you do, feel free to go ahead and talk.
Thank you so much for asking me to be here. It's definitely an honor and a privilege to be able to serve in this role. There's no greater pleasure that I have than to come to work every day and be able to serve our fellow Arkansans by helping them through where we currently are with our Medicaid backlog.
And that backlog is coming down, but if y'all would ever have that opportunity, and I encourage you to come by, but Lori has an amazing amount of patience with your constituents and their issues, and of course, they're frustrated by the time they get to her. They're frustrated by the time they get to you, and she has a great way of calming them down, helping them get through the issue to get to what she needs to help them fix it, and it's great to watch. Chairman Hendren, are you ready for an announcement, or do you have something?
Well, before you do that, Senator Chesterfield, you're recognized.
Thank you, Mr. Chair. As the government liaison, please advise DYS that I have not received the information I asked for.
That's the Freedom
in
of
this
Information.
past 3 days.
Yes, ma'am, it's Freedom of Information Act. I know that they're working on that, Senator.
And I would hope that nobody else sitting in the House or the Senate would have to go through a FOIA to get information from DHS or any of its divisions. And with that said, that's all I have to say, Mr. Chair. Thank you.
Okay, yeah, now you recognize for announcement there.
So, thanks to our legislative hosts, which of course are two chairs, Collins, Hendren, Representative Beck, and Senator Sanders. I think they're already over there at Capitol Hill, and of course, Representative Meek, David Meek, and Senator Raper, of course, are also our legislative hosts. There's one of our workers, DCFS, Department of Children and Family Services worker, that our house was burned down, confirmed as arson, and we won't go any further with that. There's not been any arrests made, but we had this, during this meeting, came up during this meeting, and they said, we wish we could find a way to help her, and I opened my mouth and I said, if we're in Yellville, we'd have a pie auction. And of course, folks within cities aren't that sure what a pie auction is, so we thought we would bring kind of a country tradition of helping folks that are in need to the city. The 6 legislative hosts have been very gracious. I know that Senator Malik and I don't see Representative Payton in here are going to be the auctioneers. They're a lot of fun to watch. I've seen both of them in action. It's a lot of fun. We've got over 50 pies over there. We've got enough chili to feed 150 people, so everybody in the audience is welcome to come over as well. And folks, if you're from the city, and I know a lot of you are, if you've not seen what a pie auction is, come on over. It's a good time. Get your billfold out. You're going to help a young lady that's in need, and we're going to have a great time, and then we'll come back and get right back to business.
Perfect, we appreciate that, and I hope you all make every effort to attend. How long is that thing scheduled to go, Kelly?
Well, 50 pies, we're going to move it quick, aren't we, Senator Malik? We hope to be back here in an hour and 15 minutes.
Why don't we say 1:30, we'll reconvene over here and try to
Awesome.
make time. All right, we'll adjourn till 1:30.